Hello, everyone, and welcome back to Pharmacology with Dr. Sokolow. Today, we are still going to talk about the principle of pharmacology, and this is the second module in which we'll still continue to describe the basic concept and background of pharmacology. First, we are going to talk about pharmacokinetics. You probably wonder what pharmacokinetic is, and to have a better idea, maybe look at this cartoon. How will that stuff get from down here, down there, up to his sore throat? Yes, this is exactly what pharmacokinetics is about. It is about what the body does to the drug and how these parameters are going to influence the intensity of the drug response that you see in your patient. So if you look at this slide, these are the different factors that are influencing the intensity of the drug response. And you probably wonder why the prescribed dose is different from the administered dose. One of the reasons are, first of all, the medication errors, but as there are a lot of progress that are made in the hospital and also in the community setting to limit those medication error, it not, you know, more likely that you'll have errors at that stage, but that will be okay if if the patient is prescribed this drug A and then instead receive drug B. Of course, the prescribed dose and the administered dose is going to be different. Now, what is more common to see a difference between the prescribed dose and the administered dose is about the patient adherence. This is very common, and this is one thing that I want to emphasize as part of your role as nurses is to educate your patient and make sure they are adhering to their treatment. So let's say a patient is prescribed a drug 2 times a day, 2 pills, 2 tablets, 2 capsule, 2 times a day. So 2 tablets in the morning and 2 tablets at bedtime, and the patient forget to take the tablets in the morning, you can understand that the prescribed dose and the administered dose is not the same. But so when this is solved, the patient is taking the right dose, the administered dose and the prescribed dose should remain the same. Now, there are some other parameters that can have an impact on the intensity of the response, and those parameters are divided into categories. You have the pharmacokinetics parameter, and then you have the pharmacodynamic parameters. The pharmacokinetics relate to the absorption, distribution, metabolism, and excretion, and the pharmacodynamic parameters are related to the drug receptor interaction, to the patient functional state, and the placebo effect. Now, I'm going to go into more detail on those specific factors, so bear with me on this slide. And so they are, of course, source of variation that can have an impact on the pharmacokinetics parameters and the pharmacodynamic parameter. For example, the physiologic variables, the pathological variable, if your patient has severe hypertension, his pathophysiologic variables are way different to somebody who has, a pre-hypertension or, is at the early stage of being diagnosed with, mild hypertension. And so those variables can have an impact on either the pharmacokinetics or the pharmacodynamic. Now, we also know that genetics play an important role on the way drugs are metabolized in the body, that there are differences between ethnicity, and some are faster metabolizer than others. And this is going to be explained in detail, not in this module, but in the next one of the future modules. So I'm not gonna, go into much detail right now, but you can understand that those variations are going to influence either the absorption of the drug from the GI tract if it's a drug that is taken orally. So the absorption means going from the GI tract to the bloodstream. and other would be, the drug receptor interaction. And if you have a stronger interaction between the drug and the receptor, the effect is going to last longer, or you can have the intensity of the drug response can be higher if you have a strong drug receptor interaction. And those parameters are the one that ultimately determine the intensity of the drug response. This intensity is determined by the concentration of the drug at the site of action. If a drug is metabolized faster because of um, some pathophysiologic condition, then you're going to have less concentration at the drug of action, or vice versa. So, what are those two areas? Pharmacokinetic is defined as the study of the absorption, distribution, metabolism, and excretion of drug, also known as ADME. And it can be resumed in one sentence: what does the body does to the drug. Now, pharmacodynamic is the study of the molecular, the biochemical, the physiology effect of drugs on cellular system and their mechanism of action. And this can be summarized by this sentence, which is what the drug does to the body. So that's when the drug is going to bind to a cellular receptor and elicit a response, an effect on that receptor. On this slide, you see different steps. The first step, when somebody is taking a medication, most often, that the most common route is the oral route. So when you have a tablet, you know that the tablet is not only composed of the active ingredient, but you have a lot of other ingredients that make that active ingredient stick in the form of a tablet. And so the first step that can influence the drug response is the dissolution of the tablet. And so that's why it's also important to drink a lot of fluid when you are taking an oral medication to facilitate the dissolution of that tablet, that capsules. And then if it dissolves faster, that's going to allow the absorption process to start earlier. And after the absorption, the drug goes from the GI system to the bloodstream, and there reach the target. And you also have the metabolism and elimination process that are going to take part in eliminating the drug from our body, from our system. So all those four criteria belong to pharmacokinetics. And then ultimately, once the drug reaches the site of action, you have an interaction with the receptors, and these are the pharmacodynamic property of the drugs. All this, of course, is studied during the preclinical and clinical trial in order to determine what is the best dose that will elicit, a sufficient response in most of the patients. But you have to keep in mind, once those dosage have been determined, in clinical trial, once you're going to work with critically ill patient, some of those parameters can have an impact on the quantity of the drug at the site of action, and therefore an impact on the action of the drug, but also on the development of adverse effects. So here on this slide, you have the four basic pharmacokinetic processes, and as I said, they are known as ADME: absorption, distribution, metabolism, and excretion. So again, for a drug that is taken orally, the first step is to dissolve in the GI tract, and then the drug is going to leave the GI tract through the membrane to reach the bloodstream. From the bloodstream, the drug is gonna again exit the blood vessel and reach the site of action. And this is a reversible process. So Some are going to bind the site of action, release, and then going to be reaching the liver to be metabolized and the kidney to be excreted. Some can also be excreted in the bile and excreted that way, but the most common route of excretion for most of the drug is through the kidney. So ideally, you want a drug, that would go straight to the site of action, exert the effect, and then when the response is has occurred, then will leave the site of action and go to the liver to be metabolized. But in reality, you have a little bit of everything that's happening at the same time. And then again, those properties are studied in those clinical trials, but it is important to know where the drug is metabolized and what are those pharmacokinetic parameters in the situation when you are working with patients who are, you know, um, with liver function impairment or kidney function impairment, because that can affect the way that the drug is going to be removed from the body. And in that case, the drug is going to remain longer, and that means you can see, a longer effect, which is that okay, it's good, the drug is going to work longer, but on the other side, you can have more adverse effect because the drug stay longer in the body, or you have too much of that drug at the site of action because the drug is not being metabolized and excreted at the same rate as a patient who has a normal liver function or normal kidney function. So by applying the knowledge of those pharmacokinetic to drug therapy, we can help maximize the beneficial effect and minimize the harm. So as I showed in the previous slide, the first step for an oral medication to reach the bloodstream is to be absorbed from the GI tract. And so absorption is defined as the movement of a drug from its site of administration into the blood. And the rate of absorption is going to determine how soon the effect will begin. Because if the drug can, move freely from one side to the bloodstream, and then the bloodstream from there is going to be carried to the site of action, you can understand that if a drug is absorbed quickly, then you'll have faster response. Now, another factor that can have an impact on the intensity of the effect is the amount that is absorbed. Because if you're taking an oral medication and everything is broken down into like pieces in the stomach because of the acidity of the stomach, and there is nothing that is left to be absorbed, you won't have much of an effect. And so, the amount of absorption is really going to determine how intense the effect is going to be. So what are the factors that are affecting the drug absorption? First, you have the rate of dissolution. Most of the oral medication are tablet, capsule, but some can be syrup. Like in the pediatric population, you will see a lot of syrup preparation. Or an elderly that cannot swallow, you can also see switch to a syrup formulation. In that case, the active ingredient is already solubilized, so that's why sometimes you can see that there is a conversion between a tablet versus a syrup. Most of the case, drugs that are really safe, you're going to have the same amount of drug in your syrup than in your tablet. For if you calculate per kilo, if it's in pediatric population. But if it's something that it's absorb more quickly, you may have some smaller dose when you switch to a syrup formulation, because the syrup, as I said, it's already dissolved, and so therefore it's going to be absorbed faster than a tablet that needs to dissolve in order to be released from that tablet. Now, the surface area where the drug is going to be absorbed is also a factor that is affecting the drug absorption. So, you probably know from your pathophysiology courses that the lining of the stomach and the lining of the small intestine are different, and that the surface area is much more important in the small intestine. So, the absorption of a drug is going to be much faster in the small intestine compared to the stomach. Now, the blood flow is very important too. If you wash out with, if the site of absorption is washed out with a good blood flow, then the drug is going to be removed and absorbed and go to the blood flow, and then it's going to reach the site of action faster. So, more rapidly absorbed from the site where the blood flow is high. The lipid solubility in order to cross the GI cells, whether it's in the stomach or the intestine, the drug is going to have to cross a lipid bilayer. And so, to cross that lipid bilayer, the drug has to have high lipids solubility in order to be absorbed more rapidly. pH partitioning, this is also going to determine based on the pH of the media that the drug is going through, that can affect how much of the drug is going to be absorbed from the stomach and how much is going to be absorbed from the small intestine, because you know that the stomach is way more acidic than the intestine, and so this different of pH can affect the solubilization of the drug, and therefore the speed by which the drug is going to cross the membrane. So pH partitioning can enhance the absorption of the drug that will preferentially ionize in the plasma. And this pH partitioning is actually used, this is a method that is used in toxicology to remove some drugs in case of poisoning. Now, how do drugs cross membranes? So we are going to see how that happens and what is important for drug to cross the membrane. So the membrane structure is a determining factor that going to impact a drug to cross the membrane, the way the drug can cross the cell membrane, and then of course the molecule chemistry. So as I said, the drug needs to cross this lipid bilayer. So if you have, most of the drug are, I would say, medium-sized molecule. They are not, huge molecules, and they are organic compounds. They are too big to be able to use the transmembrane protein, those little ion channel, and they may be too small to be transported by those glycoprotein, and I'm going to explain this in the next slide. So again, this is some basics from the physiology of the cell membrane. So it's a lipid bilayer, and what is facing out are the phosphate component face out and is water soluble, and the lipid component, so you see here those little tails, are the long chain hydrocarbon. Inner part is very hydrophobic or lipophilic. And in order to cross that lipid bilayer, the drug must be somewhat lipid soluble. Now, as I mentioned, there are different ways the drug can be transported. So first, if it's a small molecule, like potassium or sodium, those ions can be used for people who have imbalance in those ions, or some molecule or salt of potassium and sodium. And so when they are deionized, they are going to cross the membrane to the channels and their pores. The other mechanisms are the P-glycoprotein, which is a transmembrane protein that is an active transport, and these are transporters for large molecules. But the most common way of penetration of the membrane is the direct penetration, the passive diffusion So this is a movement of a substance from an area of higher concentration to one of the lower concentration. So going from the GI tract through the membrane to the cell lining of your guts into the bloodstream where you don't have, a lot of that molecule yet, and so it's going to just diffuse by passive diffusion. So here you see the passive transport for the small ion. You have the channel protein for the sodium and potassium, that can cross directly through those small channel protein. But most of the drug, like those little double pink, that they are just going to diffuse through passive diffusion. No other bigger, larger protein that may not be liposoluble may use these glycoprotein transporters, and this is a common form of transport in the kidney cells to excrete the metabolites of the drug outside into the urine. Now, what are polar molecules? A polar molecule has an even distribution of charge. So I'm sending you back to your chemistry courses. And so they have an uneven distribution of charge, but no net charge. It's not an ionized molecule. It's not an ion. So you see there is no net charge like this canamycin. You see this is an organic, if you remember your organic chemistry, and I'm not asking you to know this formula, but what you have to understand is like they have no net charge and therefore they can dissolve in water. And so they are going to be, in which if they dissolve in water, then that enable them to dissolve in the lipid bilayer of the cell membrane. So ions are different because ions are molecules that have a net electrical charge, either positive or negative, and because they are charged, they are not going to be able to cross the cell membrane. For example, the quaternary ammonium compounds like rocuronium, which is used in, like muscle relaxant, they cannot be administered orally because they would not be able to cross the membrane. So these are compounds that are injected, so then you can bypass the crossing of the membrane. And I will talk about this when we talk about agents that are used parenterally. And now I talk about pH partition or pH dependent ionization. Again, these are concepts that were that you probably learned in chemistry, and I don't have time to go into full detail about the pH dependent ionization. So if you have to review that concept, I'm going to send you back to your chemistry course. But I'm going to try to explain you the basics. So most of the drugs, they are weak acid or weak base, which mean, when they are either in environment that is either acidic or basic, their ionization is going to be different based on the pH of the environment they are in. And so that means their ionization is going to be determined by the pH of the biological fluid. Biological fluid, again, it can be the pH in the stomach, pH in the intestine, pH in the plasma, pH in the urine. All these are going to be different, and then therefore are going to impact the absorption from one compartment to the other. And then ion trapping of a drug is when the pH of a biological fluids are different in each side of the cell membrane. So as I explained, so the pH is going to be different between the stomach versus the plasma, or between the plasma versus urine. And so a drug can be trapped. The ionized form of a drug is going to be trapped in the side where the pH is more favorable for the drug ionization. And I'm going to try to explain this to you using this slide. So this is the example of aspirin. So aspirin, it's a weak acid. And here we're going to talk about the ionization of aspirin in the stomach. In the stomach, it's an acid. It's slightly acid. You see pH 8 or 1, and so you see that the pH 1 is not in favor of the ionization of aspirin. So if you look at those two arrows, you see that the biggest arrow is more in favor of the non-ionized form of aspirin, because aspirin, an acid in an acidic media, tends to stay non-ionized. And you remember what we said is like the polar molecules are the one that can cross the membrane, because if you have an ion, that ion is not going to be able to cross the membrane. So great. So here you have aspirin that is mostly in the non-ionized form and going to be able to cross the membrane by passive diffusion. And then once it crossed the membrane, so this is step 2. You see step 3, now you have this ionized aspirin that is now in the plasma where the pH is higher, which means it's not really basic, it's more neutral, but it's more basic than the stomach. So in that case, it favored the ionization of aspirin. And when it's ionized, remember when it has a charge, it cannot go back and cross the membrane, which is good. So then now your aspirin is in the bloodstream and can be, carried and reach the target of action and exert its effect, whether it's to reduce the fever or reduce pain. But now you have the most of the non-ionized form of aspirin stays trapped in the plasma and can go exert its action on its target. Now, the opposite, if you have a basic drug, the basic drug is going to tend to ionize in the acidic media. So that means here in the lining of the stomach, if you have a basic drug, pretty much nothing is going to cross to the plasma. But good news, as the drug goes down into the GI tract and reach the intestine, which is more basic, it's less acidic, I would say. I'm not going to say it's basic. It's less acidic. It's going to kind of favor, the dissociation there in the intestine, and then going to be absorbed. And also, as I said, you have a much wider surface area to be absorbed, so it's going to favor the absorption of basic drug when it's lower in the GI tract. And those concepts of ion trap ionization, as I said, it's important, and these properties are actually used to favor like the excretion of a drug in case of toxicity. You can modify the acidity of either the urine to try to favor like the excretion, for example, of amphetamine. If you increase the acidity of the urine, then the amphetamine is going to be stuck in the acidic media in form of it's going to be ionized there, and therefore if it's ionized in the urine, it's going to be trapped in the urine and excreted. Now, if you have, so let's go back to this. So ASA stand for so it's aspirin. It's acetyl salicylic acid. pKa, I'm not asking you to know the pKa, but if you remember from your chemistry course, a low pKa is an indicator of the acidity of a compound, and a higher pKa would be indicators of a more basic compound. So drugs that are more acidic are going to be ion trapped in the plasma compartment after absorption, because when they are in a more basic, even though plasma is more neutral, but less acidic, then um, the stomach is going to be trapped there and then become dissociated. And then that means when it's dissociated, when it's ionized, it cannot go back to the stomach. It's trapped where you want. It's trapped right there in the blood flow, and then it can be distributed to the site of action. Now you see amphetamine, which is more a basic drug, is going to be ion trap, ion trap in the stomach at low pH. It's going to be dissociated and ionized. And as I said, if you have a toxicology problem with amphetamine, somebody who's overdosing, with some of the street drug, this is more relevant, than saying, okay, the amphetamine is going to be ion trapped in the stomach. Here, what I want to say is like, you have, you see the blood is about 7.4 and the urine is 6. And if you give, as I said, if you give vitamin C, which is going to make the urine even more acidic, what's going to happen with that basic drug? So you see the basic drug, when it's on more basic pH, like 7.4, you see that the arrow is in favor of the non-ionized form. And the non-ionized form is going to cross the membrane once you get to the urine, which has a more acidic pH. And this, as I said, you can even manipulate that, make it even more acidic. You see that in a more acidic pH, you have now the main arrow towards the ionized form, with you see the charge. When it's charged, it bonds back because the drug cannot cross back to the plasma, and that's how you can eliminate this drug faster. And how neat it can be when you have toxicity and intoxication, to manipulate the pH of urine and eliminate the drug faster. So I hope you understand the concept. And again, when we'll meet in class, I'll be happy to answer questions if you have questions about the pH partitioning. Now we are going to move on and talk about the commonly used route of administration. So there are like two main routes, especially in the hospital. There's all going to be the two main routes that you're going to be facing. The parenteral, for patients who cannot swallow at the time you are seeing them. And then you have the enteral, which is the oral form, and that's via the GI tract. This is, the most common form outside the acute care setting, but even in the hospital, you see, you still give a lot of drugs per us, or orally. And then you have the parenteral route, more like for the emergency situation. You have the IV, the IM, intramuscular, and then sub-Q, which stands for subcutaneous. So parenteral means outside the GI tract by injection, compared to enteral via the GI tract, oral or PO. And then, of course, those routes are going to affect the onset and the intensity of the drug effect. And we will talk about that in the next module. So I hope you enjoy this module, and I will see you soon in the next one. Thank you.